Hello, my name is Edward Vieta. I'm professor of psychiatry at the University of Barcelona, and I'm co-chairing this ACUMEN initiative that is endorsed by the World Federation of Societies of Biological Psychiatry, dealing with cognition in schizophrenia and mood disorders. Today we're going to discuss the pharmacological treatment of cognitive dysfunction in bipolar I disorder. The objective of this session will be first to assess the safety and efficacy of pharmacological treatments for cognitive dysfunction in bipolar I disorder. Secondly, we would like to apply the knowledge learned from clinical trials in clinical practice. So how can we actually apply those therapies in patients in the real world? And finally, we would like to understand much better the mechanisms and the pathways that drive cognitive impairment in this condition. On that purpose, we have my great friend and colleague Michael Berg, who is professor of psychiatry at Deakin University, and he is an expert on the management of cognition in bipolar I disorder. Hi, Michael.
Hi, Edward.
So, Michael, tell me, what drugs have been studied in the treatment of cognitive dysfunction for bipolar disorder?
Well, cognitive dysfunction in bipolar disorder has only recently been recognized as a significant clinical problem. For a long time, clinicians have focused on symptoms, more recently on functioning. But it's really only in the last decade that people have recognized that cognition is a major challenge that people with bipolar disorder face. I guess the similar pattern has emerged in schizophrenia, where cognition has also emerged as a major symptomatic domain, necessitating recognition and treatment in its own right. But this is a relatively new area for bipolar disorder. The clinical need is understood, but the research is only beginning to understand what treatments might be useful. There are areas of considerable promise, but there's still a lot of uncertainty.
What is the efficacy of these agents?
Well, the efficacy of these agents is supported by early clinical trials. I think it's fair to say that for none of the agents that we are looking at, we have a robust body of evidence. We certainly don't have multiple replicated clinical trials with meta-analytic level of evidence. So I think that probably needs to be said up front. One of the things that's been more recently understood is that one of the oldest treatments we've got, which is lithium, actually has significant benefits in terms of cognition. There are a couple of studies, particularly in early stage illness, which suggest that people taking lithium have preserved cognitive functioning. That's a major important piece of information for clinicians to understand. And I think it should, to some extent, guide treatment choice and also guide patterns of treatment. But there's some really exciting novel treatments as well. There's some data of the atypical antipsychotic lurasidone, and there's some early clinical trials that suggest that it may have pro-cognitive effects. There are some larger scale, more definitive studies that are underway, but at this point this is an important clinical lead. Then there's some more experimental strategies. So there's some data from the Danish group that EPO, erythropoietin, which is used by cyclists worldwide, which might actually improve cognition in people with bipolar disorder. Again, early stage trials and needing replication. There's some very early evidence that N-acetylcysteine might be associated with improvements in cognition. Again, tentative early data and definitely needing definitive replication.
In my experience, some clinicians might argue that lithium can be somewhat neurotoxic or cause some cognitive dysfunction.
That is a perception that used to be held, but that's not well supported by well-conducted trials, which seem to suggest the opposite. There's no question that lithium can cause a subjective sense of graying or dulling in some patients, but certainly not the majority. But it is a side effect that clinicians will hear. But there's pretty good clinical trial evidence head-to-head that lithium is associated with preservation of cognitive functioning, particularly in early-stage illness. And I think at this point it's probably worth mentioning that if you look at studies of cognition in people who are at risk of developing bipolar disorder, their cognition is, if anything, superior to their peers. So we need to frame any discussion about cognition in bipolar, understanding that these are people who are, on aggregate, quite talented, smart, and gifted people. And the fact that there is cognitive problems in people with bipolar disorder is testament to the fact that there's probably some active disease process that impacts cognition. So the studies that seem to show the best effect on cognition are in young people. And essentially what they seem to show is preservation of cognition. There's a parallel but quite distinct group of literature on lithium and dementia. We know that people with mood disorders are at greater risk of developing dementia, but this is not true of people who take lithium. They seem to be relatively protected against dementia. And there's one or two not great studies, but they actually seem to show that lithium might prevent the trajectory of cognitive decline in people at risk, but also that there might be reductions in key dementia biomarkers associated with lithium treatment. So the new evidence does suggest that, in contrast to the preconception that lithium was neurotoxic, it's actually neuroprotective.
Uh-huh. And we're talking about pharmacological treatments, but obviously there are other interventions that are also relevant.
Absolutely. So there's certainly cognitive remediation strategies, and there's now quite a significant high-quality evidence base that cognitive remediation might be useful to people with bipolar disorder. The same is known in schizophrenia, that cognitive remediation may be helpful. But that's not the only thing you can do. We know, for example, in dementia, the most important risk factors are diet and physical activity. And while there hasn't been a lot of randomized controlled trials looking at that in bipolar disorder, I would be very surprised if the same is not true of bipolar disorder, that physical activity and good quality Mediterranean type diet is probably neuroprotective too, and might help in the protection of cognition.
We said that in the learning objectives that we would like to apply the knowledge from clinical trials to clinical practice. So what is the efficacy of these agents in clinical practice? How do you select the agents for treating cognitive dysfunction in bipolar I disorder?
Well, I think that's a very important point, because all this theoretical knowledge isn't of much value unless it influences practice. So the first is to understand that cognition is an important symptomatic domain that clinicians actually can target. So the first issue is to be aware that there are differential effects of pharmacotherapies, that available pharmacotherapies differ in their propensity to be neuroprotective and protect cognition. So if a clinician, in addition to all the other properties that an agent might have that influence clinical decision making, takes into consideration that some agents might be neuroprotective, that goes a long way to assist in clinical decision making. But again, while we're talking about pharmacotherapy, it's essential to note that cognitive remediation strategies and healthy lifestyle strategies are a core element of preservation, not only of cognition, but also of physical health and also of mental health, because we now know that attention to lifestyle factors and the holy trinity, the holy trio are smoking cessation, reduction of substance abuse, physical activity, and healthy diet. All of those are toxic to the brain. We know cannabis abuse is toxic to the brain. Smoking is associated with cognitive decline, risk of dementia, and cortical thinning, and is reversible by stopping smoking. And we know that both diet and physical activity are protective of cognition in general populations. And an important change in practice is, I think, at this point in time, enough is known about those lifestyle factors for clinicians to be prescribing them as routine elements of clinical care, which wasn't the case even 5 years ago.
Yeah, but that's my impression. We learned a lot over the past decade about these, factors and the importance of cognition, but we're still a bit far away from really assessing cognition, assessing functionality, and implementing these healthy habits that you're actually advising. Right?
Absolutely. We need to be able to convey the message that there are multiple benefits in terms of clinicians having an active role in lifestyle modification. There are benefits not only to cognition, which is what we're talking about today, But we know that there are now benefits to mental health. There's benefits to non-communicable physical disorders like diabetes, heart disease, which is the major health problem of people with bipolar disorder and schizophrenia. And we know that it's associated with improved longevity. So there are multiple reasons why clinicians need to be very much more active in pursuing lifestyle goals than they might have in the past.
And what are the pathways that underpin cognitive dysfunction in bipolar 1 disorder?
Well, it's not really completely understood. There are a number of pathways that we think are implicated. Probably top of the list is inflammation. We know that bipolar disorder, for that matter depression, schizophrenia, is associated with a pro-inflammatory state. And there's now pretty good evidence that inflammation is associated with alteration in brain structure and cognition in bipolar disorder. In fact, there was some very nice new material presented at the WFSBP meeting this morning showing an association between inflammation and structural brain changes, particularly white matter changes, and cognition changes. So inflammation seems to be a key root. Important to note that physical activity, smoking cessation, and diet reduce inflammation. And we also know that lithium has effects on inflammation.
So how can one ameliorate these pathways?
The way that one can ameliorate these pathways is by engaging treatments that have effects on those pathways. So these are the lifestyle factors that I mentioned, as well as some pharmacotherapies that have effects on these pathways. So antidepressants have some anti-inflammatory properties, some antipsychotics, but not all have anti-inflammatory properties, and lithium definitely has anti-inflammatory properties. The other pathways that are involved are oxidative stress pathways, tightly linked to inflammation, and we know that oxidative stress is also associated with the process of neuroprogression and cognitive and structural brain changes. What's more recently understood is that mitochondrial dysfunction, this is abnormality in the body's capacity to generate energy, is present in bipolar disorder to a significant extent, and this might also drive the process.
You mentioned oxidative stress and neuroprogression, and maybe one could speculate that actually the number of episodes, recurrence, might be associated to increased oxidative stress and neuroprogression.
That's absolutely the case. So one of the things we know is that in an acute episode of illness, one has much higher levels of inflammatory and oxidative markers. They do settle to a significant extent, but not uniformly, in people who go into remission. So it's episodes of illness that are toxic. So one of the things that goes a long way to prevent the toxic consequences of the illness is to prevent recurrence. In order to do this, then standard chronic disease management strategies focus on adherence, focus on engagement, focus on long-term continuity of care. Those are the things that make a huge difference, as does psychoeducation. So those elements are very important to relapse prevention, and they have a direct effect in preventing the toxic consequences of relapse.
The other clinical feature that is somewhat controversial is psychosis. To what extent psychosis is actually involved in cognitive impairment in bipolar disorder?
Yes, as you say, this is a bit of a controversial area. There's no question in schizophrenia that it's a very direct process. But whether psychosis is a direct pathophysiological element that has independent toxicity in bipolar disorder is not clear. It's quite likely that it's an epiphenomenon of severity or acuity. We also know that psychosis in bipolar disorder does not necessarily need antipsychotics to settle. So the few studies that have compared lithium and antipsychotics for the treatment of psychosis seems to show that they're equivalent. So whatever gets you out of the acute episode of illness will assist in getting rid of the psychosis. You don't necessarily need an antipsychotic.
So would you say that cognitive dysfunction is actually a state or a trait marker of bipolar disorder?
This is a complex issue, and there's a parallel argument in depression. There's no question in acute illness, and again, the literature is probably better in depression than in bipolar disorder, that in acute illness, one tends to have more cognitive symptoms because you have the compounding effects of the impact of illness acuity on cognitive processes together with whatever active process of neuroprogression exists. But when one goes into a remission, the neuroprogressive process remains, but the effects of acute illness dissipate. So they're intertwined and they're bidirectional.
Michael, is there room for early intervention in the treatment of cognitive dysfunction in bipolar 1 disorder?
I think that's an excellent question. And I think the answer has to be yes. The reason being that if you conceptualize the cognitive changes as something that occur from a normal or superior baseline progressively over time, driven by recurrent episodes of illness, then getting in early is essential. It's much less helpful to try and address cognition once significant structural brain change has occurred or once significant cognitive changes have occurred. So I think it's essential to get your best treatments up front at the beginning of the illness, and it's prevention of recurrence, prevention of episode cascade, and therefore the prevention of the toxic metabolic consequences of illness that is most likely to preserve cognition. So I think it goes to the argument of needing to commence optimal mood stabilization therapy, ideally with agents that have known potential protective effects on cognition as early as possible. It also then talks to the importance of maintenance of effective prophylactic therapy as early as possible. This is quite important because there's a bit of a paradigm shift in that it wasn't many years ago where clinicians were advising their patients to not start mood stabilizers until they've had a few episodes of illness.
I remember that, yeah.
And now we understand, because of the process of neuroprogression, that that's probably unwise advice, because we want to prevent the consequences of illness. We don't want to be using our mood stabilizer and lifestyle and cognitive psychological therapies while cognition decline has already occurred. We want to do it early enough that we can prevent this. So I think early intervention is critical, and we need to be using these interventions as early as possible in the illness course.
So, Michael, we've been discussing a lot of issues around cognitive dysfunction in bipolar 1 disorder, and I really appreciate your answers. Could you wrap up and summarize the three major key points from our conversation today?
Well, I think that the three key things that clinicians need to understand is that cognition is a significant domain of symptomatology in bipolar disorder. Secondly, clinicians need to know that some pharmacotherapies do have potentially beneficial effects in the domain of cognition. And I think it's useful for clinicians to know which agents are useful. For example, some atypical antipsychotics and lithium. Which agents are not useful, for example, typical antipsychotics. And it's also important for clinicians to understand the mechanisms and pathways which drive cognitive impairment. So that's not only the biological pathways, but also the lifestyle pathways, because clinicians can directly impact those.
Thank you very much for your time, Michael.
Thank you.